Assalamu alaikum. Welcome to the APPNA Merit online webinar series. Today we got a very important topic, and that is regarding the COVID vaccination and the common myths we have, or our community have on COVID, unfortunately. It's very important because, as you're all aware, that although we are now in the third wave, but the cases are getting very high. And yesterday, as reported from different cities of KP, the positivity rate was well above 20% in most of the major cities. I hope it's not going to be the same in all the major cities across Pakistan. But today, another article just came through in which we have noted that a lot of school children are coming positive as well, which was area which people used to kind of easily ignore before, and we were thinking that children are not getting affected. But now the worry is like even if they not got serious conditions, whether they will be contributing to the spread of the disease. So we are in a very important time period where we definitely need to look at our strategy. So vaccination, as all the governments across the globe are emphasizing on, is a very important area we need to address. And unfortunately, because of the common myths, if we don't address it in time, there is a risk that people will start avoiding the vaccine. So that's why we APPNA Merit decided to do this important topic today. I'm not going to take too long. Adil, as we discussed, Dr. Adil Riaz is going to be our speaker today. Adil is a consultant family physician at UK, but his other most important head is at the moment is because he's himself is working on the COVID hot side. In UK, we call it the hot side, where all the patients with suspected symptoms are going to be seen by the GPs. And I've also seen him doing similar sessions across UK for our what we call BAME community, or our Asian community, which were seriously affected during the COVID. So as I said, all the questions we may have for him, he might have already been asked by a lot of people. So simple rules for this, most of the attendees who already know that they're going to be first 30 minutes will be the speaker talk. If they have any question, they can raise the question, they can type the question in the question answer session. For our panelists, if they feel they can answer the question, they can reply it there. Or at the end of the 30-minute session, we will have then question answer sessions. You can have questions for the speakers and for the panelists, and we will try our best to answer them. So I'm not going to take too long, and I will hand over to our guest speaker, Dr. Adil Riaz. Welcome, Dr. Adil.
Assalamu alaikum wa rahmatullahi jazakallah khair, Dr. Jalil, for introducing me. And thank you to APPNA Merit for organizing this talk on obviously the hot topic which is going around at the moment. So I'm just going to share my screen so you can see this all. Okay, so firstly, thank you very much for all of you to give us your time on Sunday, and thank you very much to all the panelists. So I'm fortunate to have this team panelists. We've got Dr. Ridwan from Birmingham, UK, a senior doctor here, consultant family physician. We've got Dr. Shafiq from Saudi Arabia, King Abdullah University in Science and Technology, Dr. Hina from Lahore, and Dr. Abdul Jalil from Peshawar. So hopefully we'll have a good mix of experiences. So today's talk is not to teach you about COVID itself, and most of the things I would talk, you probably would know most of these things anyway, but the idea is to make you aware of the current conspiracies which are going around, or the myths or misunderstandings that people have about COVID-19 vaccination and how to address them. So the idea of this talk is to equip you to, when you deal with your patients or with your fellow community members, your family members, and they have heard something on the internet or WhatsApp or social media somewhere, and they come to you for questions. So just to prepare you a bit more, there's plenty of data going around at the moment that Pakistan is one of the country with the highest hesitancy towards the vaccine. So all of you as frontline health workers, your role is extremely important. And if some of you have got any doubts about COVID vaccination, we hope that today's talk would clarify some of those. And we'll be happy to answer any questions. So I work as a physician in the COVID clinic. I don't have any conflict of interest when it comes to the vaccines, but I've been working in the COVID site in one of the worst hit areas in the country, in UK, for last 1 year. I started working there in March. I, like many other of my colleagues here in UK, already had both vaccines. So I had Pfizer vaccine. It's the first one that came here, so we ended up having it. I'm also using some of the information from British Islamic Medical Association, BIMA, in this slide, so I thought to thank them for this. But I don't have any financial conflict of interest. I'm not being paid by any drug companies. I know in Pakistan, all over the world, to be fair, this is something which people say quite often, that the drug companies are quite strong and they buy people over. I haven't been even given a pen over the last few years from a drug company. So there's no conflict of interest. And it's very important that all of the doctors are quite up and open and honest about this. So before we talk about vaccination itself, it's important to realize about COVID, what COVID is, and it is actually real, and look at the actual data which we have got in hand. It's been more than a year now since pandemic hit all over the world, and there's plenty of data for us to look at. So before we try to clarify any myths, it's important to realize if there is a problem, and if it is a problem, then how bad it is, because we've heard people saying quite often, oh, it's just like simple flu, or this is just a hyped up thing people have made. And I, by the way, apologize in advance. You might see me using UK and the data from UK quite often. I've tried to add few slides from Pakistan and data from Pakistan, but in UK, the thing we probably have been good at is collecting data. So there's plenty of information. And we have a lot to learn from what we have been through in UK. We had one of the worst COVID pandemic here, and there are lots of mistakes that were done here. And it's important that people learn from the mistakes we do. So I've added slides mainly with our own experiences and the data which is available here. So the one on bottom left, you can see the intensive care admission data. So this is up till December. And you can see a sudden, in December, we were actually hitting towards our second wave. And you can see the increase in intensive care admission for all age ranges, apart from children. We had a dip in elderly. And the other thing which you need to keep in mind is that this data is in spite of all the lockdowns. So we had quite strict lockdowns here. And so I know in Saudi Arabia and certain parts of Pakistan, they had quite strict lockdowns. So these are all the data we've got in spite of the lockdowns. So the way intensive care admission is important to look at that is that's kind of a marker for you to tell how bad the disease is and what's the expected death rate. So whatever your positivity rate is, it will translate into hospital admissions after 2 to 3 weeks. And after 2 to 3 weeks, hospital admission will be intensive care admissions after another 2 weeks. And after another 2 to 3 weeks of intensive care admissions would be the death data. So this is how it looks at. And COVID controlling strategy all over the world, the main aim behind that was to reduce the workload in hospitals. You can decide all the other aims, but the actual main objective was to reduce the workload on the healthcare services. And intensive care is probably the only life-saving place for COVID patients. So that's why looking at the intensive care data is quite important. And the criteria we use here in primary care, and I think most of the audience today are from primary care or frontline physicians as well, that anyone who's got oxygen saturation of less than 92 to 93%, we send them to hospital. So most of the times when you end up in hospital, you'll get this high flow oxygen. And quite a few patients then end up on positive pressure ventilation. And the way I explain this to our patients and the way you can explain to your patient is that positive airway pressure ventilation is like a car is driving at 70 miles per hour and you have your face outside the car window. The way you feel the air pressure on your face, this is the kind of pressure you get when you get these positive airway ventilation, non-invasive ventilation. And this high pressure, imagine having that 24/7 for days in and out. It's not easy at all, and may Allah save us all from this. But it's important to know that there are lots of patients who end up having this non-invasive ventilation. And then obviously people end up in intensive care. And I know currently in Pakistan, you're going through your second or third wave, and intensive care units are already inundated. So people get obviously ventilated intensive care and the multidisciplinary team. In UK, in the first wave, our death rate was actually around 60 to 70% once you admitted to intensive care, and now thankfully did improve, and the death rate was reduced to 30 to 40%, which is still very, very high. In places like Pakistan, probably the death rate would be quite high once you end up in an intensive care unit. The other thing which is very important and which I realized when I was seeing the patients and when you hear people who have got various videos uploaded, that they say, oh, in the winters, hospitals are busy anyway. So that's why I added these two slides. So if you look at this one on the right above the graph there, so the line which is the dark line, it gives you the COVID death in UK in the month of January. Well, in last 1 year from January to January. And the dotted line is actually the 5-year average. So in UK on average, 1 year, in 1 year, we got around 500,000 deaths, around 500,000 deaths. Sometimes there are 15, 20,000 above, and sometimes there are 15 or 20,000 less. So this would tell you or the COVID death in last 1 year, and you say it's way above the 5-year average. So in the first peak, when we had in March, April and May, we had the first peak, and look at the 5-year average was bottom here. And then this is the last peak which we had, which we actually, this data ended up in January. This graph went much higher after that. We really had a bad January here because of the new variant. And the other thing which is quite interesting in this bottom graph, you would see that the blue color are the COVID deaths and the green color are the non-COVID deaths. And the dotted line in the middle is the 5-year average. And you would see that in the first peak and in the second peak here, we were way above the 5-year average here in UK. And if anything, the interesting bit, because of the lockdown, the non-COVID deaths actually reduced, thankfully. And I was working in the red site, and in August, September, we were really worried that in winters, we are quite busy here in UK because of the normal winter viruses that will get inundated with winter viruses because it's difficult to differentiate between two. But thankfully, because of lockdown, we didn't see much, and because the schools were closed. And now with the schools have opened up here, we've seen the increase in the normal seasonal flu. But in spite of all these lockdowns, you can see these big peaks going up. And the 5-year average is sitting here, which we normally increase in the winter months here. But with COVID, it was way above. So, and these data is actually from, we've got an independent authority here, we call it ONS, Office of National Statistics. So this data has been taken from there, and they take the information from the death certificates. So it's quite obvious that COVID definitely hit us bad here in UK. So the numbers, we had 4.3 million people who tested positive for COVID, and up till yesterday, we had 126,382 deaths here in UK. They're actually, these are all excess deaths. So we are already excess above 130,000. So we already had around 630,000 deaths in last 1 year, when the average is around 500,000. So we are already way above our excess. So total deaths worldwide are about 2.76 million. And we know that this number is quite significantly underrepresented because the data record in other parts of the world is not as good. So in Pakistan, 642,000 positive cases so far, and the total deaths are 14,028. Now, this is obviously amazing in the sense that every death obviously is bad, but compared to what we had here in UK, our population is 1/3 of the Pakistan's population. The deaths in Pakistan are quite low. We know that there are multiple factors behind that. Obvious one is the data record. The deaths are not as well recorded there, and then the COVID diagnosis is even an issue. But down the line, I think we'll know better once the deaths get registered that how high it was with the 5-year average. But even if we increase these numbers 3, 4, 4-fold, Pakistan has still done better. But the fear is that this might not last as the new variants are coming up, and people have not been vaccinated as much. The other figure, which let's move this slide. Yeah, I find this graph, there's one of the last graphs. I'm not going to put too many ahead. The excess deaths age-wise, and you notice people above the age of 65 and all the way to 85 plus. We had more than 100% excess deaths. So normally, for example, in children, the registered death was 1,355 in men, and expected was 1,546. But actual deaths were less, so we were less than average in children. But when we come to elderly, we were expecting deaths to be 63,000, but actual number was much higher. So more than 100% increase, both in men and women. Men were slightly more affected than women, but it affected everyone. So in Pakistan, you're almost having 3,500 to 4,000 cases per day, and the fear is that you are hitting towards your second peak now. So in 17th of June was the highest recorded cases in Pakistan at that time, and then things got easier. And probably the defenses were relaxed, the lockdown measures were not there, the gathering and social distances were not as much, plus the new variants from all over the world started to arrive here, and we're seeing the effect of that, and it's affecting every city now. Dr. Jalil at the start mentioned 20% positivity rate. This is extremely high. I think in UK, even in the worst of the times, our positivity rate was around 5%. So 5 out of 100 tests done, and I think in certain areas it went up to 7%, but nowhere near 20%. So if you're having 20% positivity rate, this is extremely high. And I think we'll talk to our colleagues in Pakistan, and they can enlighten us why the death rate is, thankfully, the death rate is not that high in Pakistan. So just talking a bit more about the new variant, that why it is dangerous. Now this slide was done by my colleagues in BIMA, and it's talking about the Kent variant. The first variant that was identified here was in Kent, a place near UK, near London in UK, and the studies, and suddenly, because we've seen the sudden rise in the infections here, and then they realized it was down to the new variant, and it was 70% more transmissible compared to the normal original COVID-19. So these statistics were done that if 10,000 people get the old normal COVID-19, after 1 month of the spread, 129 deaths would happen. But if you only consider as 50% more transmissible, not even 70%, then with 10,000 people get it infected with the same social distancing rule and everything else, and if we consider the virus is not even more dangerous, I mean, there are studies that it actually is more dangerous as well, but if it's as dangerous as the first COVID-19, but just because it's 50% more transmissible, it will kill 978,000, almost 1,000 patients people after 1 month. So such a huge difference. And that's why the lockdowns and these all type of things are important to slow down the spread, because these new variants, they spread so quickly. And if obviously the more people who get it, the more are likely to die. We were badly affected here in Birmingham when it comes to ethnic minorities, or BAM community, we call as Black and Asian minority ethnic groups. We make around 6 to 7% of population here in UK, and actually with the deaths we were around 30%. So the death rate was significantly high, and there are various reasons behind that, social and medical reasons. But places in Birmingham where I'm based and where Dr. Rizwan is based, we really had the worst of it, and there are mosques where they're doing 5 or 6 janazah in one day, and or Qabristan cemeteries, they all get filled up. So there's hardly someone you don't know who don't know anyone who's passed away in this pandemic here in UK. So there have been days where we were having basically 1,600 to 1,700 deaths per day. And I used to tell my patients and the colleagues where I used to do the things that it's like 2 Airbus A380 colliding over the skies of Britain every day, basically during the month of January. A380, like you know, takes 800 passengers, the biggest aeroplane. And these are all excess deaths. So if you look into all these, it becomes quite obvious that COVID is something real. So the question is that what to do with it, and there are 2 strategies to deal with it. When when obviously 90%, 95 or 97% of people get better, then the people say that, okay, let it spread. At the end of the day, to prevent the deaths, people need to have immunity. And there are two ways to develop the immunity. One way is to let the virus spread and let everyone get it. And then that's how the antibodies would develop, and that's how the herd immunity would develop. And the other option is to vaccinate. Doing lockdowns, even in the well-off countries, is not possible for long term. In places like Pakistan, it's definitely not possible because of the financial reasons. So these are two ways. But if we look at the first option, to let the disease spread, like the figures I've shown you before, no health system in the world can cope with this. In country like Pakistan, if you only had 1% of people who need hospital admission, you don't have 2 million beds anywhere available. I don't think you can deal with even 0.1% intensive care admission. So no country on earth can deal with. So I get amazed when people say, oh, 99% people get better anyway, it's only 1% who suffer. But people don't realize only 1% is still a huge number. We're talking about pandemic and the virus that spreads quite quickly. So 1% would collapse the whole healthcare system. And that would increase not just the COVID deaths, it would significantly increase the non-COVID deaths as well. So in UK, for example, I was talking to someone, he said, oh, the death rate is only 0.5% anyway. And I said, 0.5% is almost 700,000 people. Can you imagine having the deaths of 700? So that's why it's important to look at the numbers which I've shown you before. So that's why we feel that vaccination is the only way out. There's no other way out of this pandemic. Yes, after 5-6 years, when it becomes part of the normal seasonal virus and it will lose its potency, but until that time, you'll have millions of deaths. It'll be very difficult. So vaccination is the only way out. Scientifically, there's no other way out. So vaccination prevents actually the symptomatic COVID, and that's how the deaths are reduced. So like I said at the start, the ultimate objective is to reduce the hospital admissions so that you have bed availability. So anyone who's unwell should be able to get a hospital bed. So the strategy of the decision makers is to make sure that your hospitals don't get overloaded, and that's why you do lockdowns. What COVID does is that, and the vaccination, the data is so much out there that it definitely prevents the symptomatic COVID. The 70% prevention success rate, or 80%, 90% is actually for getting COVID. But the success rate for death and for severe COVID in some vaccination, in some cases, actually almost 100%. So it definitely makes a big difference. However, it's important to know that it does not prevent you getting COVID. You can still get COVID, like you're wearing clothes to prevent your body with the dust. Your clothes can still get the dust, but your body is not going to get it. So when you get vaccination, you can still get the virus on you, and you can give the virus to someone else. But if you are vaccinated, you're not going to get symptomatic COVID, and that's what vaccines do. So that's basically a few slides for you to understand why vaccines are important and why they're necessary. I'm so, as doctors, all of you are aware of that anyway, but it's important to let your patients know about these type of things. So in UK, we started with two vaccines, Pfizer and AstraZeneca. They were the first two vaccines that got approved anyway. AstraZeneca is coming to Pakistan as well soon. So it's important for you to know a bit. I'm not going to get into too much detail. I'm not a pathopharmacist myself as well, but briefly to know that this Pfizer is mRNA-based vaccine. So that's where, you know, this myth of gene therapy and those type of things. I've heard people talking in the media, even in Pakistan, that's a gene therapy. It's not, because it was mRNA vaccine. But what people don't realize, mRNA does not change your DNA. And this is not as new technology as people think. Actually, in 2003, the rabies vaccine was made on this technology, and there are certain other medicines which we are already using, which is based on this technology. So what they do is basically they take the spike protein of the virus, because the covering of the virus, the spikes on the virus outer shell, they are the ones that generate your body's immune system, and they're the ones that cause problems. So if you train your body to recognize these spike proteins and develop the immunity, this is what vaccines do with different methods. So what they did in Pfizer, that they took the coding of the RNA of the spike protein and they encapsulated in a lipid nanoparticle and give that in, to your body. And I had Pfizer vaccine, both of the shots, and we've seen actually it's been fairly effective. Actually, for the new variants, it's been quite good. There have been some side effects. During the trials as well, they had 44,000 people in the trial, and there have been 2 anaphylactic reactions for the vaccine. And when they started giving it, we had about 6 people who had anaphylactic reaction. No one died. But all of these people who had anaphylaxis are the ones who were known to have severe allergic reactions before. So that's why Pfizer vaccine is not recommended for those people who suffer from severe allergic reactions. So we're talking about severe allergy, like in UK, we give EpiPen to the to people with severe allergy. So if you ever had severe allergy needing adrenaline and those type of things, but normal hay fever and coughs and colds, it's okay, and we are using it. The other problem with Pfizer vaccine is that it needs to be stored at -80 degrees, and that's why countries like Pakistan and other developing world, it's not suitable. Now, AstraZeneca was combination of Oxford University. That's where the research was done, and AstraZeneca developed it. So it's the old technology where they use the viral vector. Almost 12,000 patients, people were there in the trial. They had 1 case of transverse myelitis, but they were not sure whether it's related to virus or not, but it was reported. There were no anaphylaxis. And again, it's a very, very successful vaccine with more than 80% efficacy against. So they use this chimp adenovirus as a vector. And I was talking to a brother the other day, and he said, oh, vaccine is haram because they're using chimp in this. And then I explained to him that it's a chimp adenovirus, the virus which affects the chimps but not the human. They use that virus as a vector. So as a doctor, it's important for us sometimes to clarify people if they read the ingredients and the word chimp mentioned there, that doesn't mean that it makes the vaccine haram, though no chimp has been used in this vaccine. So in Pakistan, you've got 2 vaccines. That one is the Sinopharm, the Chinese vaccine, another is the Russian one, Sputnik. Again, both of them are excellent vaccine. The Sinopharm had 60,000 people in the trial, and they've done over 7 countries, and Pakistan actually was quite actively involved in the trials as well. So the technology they use again is quite well tried and tested. So they use the inactivated virus in this. And all of these vaccines, you use 2 doses 3 weeks apart. And you know, when you look at this 70%, 80%, 90% efficacy, don't say they're only 70%, only 80%. This is amazing considering the vaccines we had before, like flu vaccination, which we normally give every year, has got 50% efficacy. So 70% or 80% efficacy is really good. The Sputnik vaccine, which is a Russian one, again, they use the same technology as the AstraZeneca. They were actually fairly similar vaccines. And they use a viral vector as well, more than 90% efficacy of this vaccine as well. They are slightly different because in the trial, they use 2 different virus vectors, because the idea was that in the second dose, we don't use the same vector. Otherwise, your body might start showing immunity towards the vector and destroy the vector. So we don't want that. So they used different vectors. I don't know whether in the real life, you've got 2 different vials, which we use as a first dose and the booster dose. I'm not sure about that, but they used 22,000 people in the trial as well. And obviously, Russian president, even the phase 3 was not completed yet. After phase 2, the Vladimir Putin ended up having the vaccine. But all of these vaccines have been through all the trials now, and they've been approved by the various regulatory bodies. So these are the common vaccines. There are obviously other vaccines. Johnson & Johnson, which is 1 shot only, has been approved by FDA in America. But I think in Pakistan, Sinopharm, Sputnik, and AstraZeneca, these are the 3 vaccines which you would be using. The way vaccine was given here in UK, I'm not going to get into the detail of that. We had the priority groups, age-related mainly, and the healthcare workers were in the second priority. So we have completed almost all of these priority lists now. I was actually searching online, and I think Dr. Jareer and Dr. Hina can guide us further about the priority groups in Pakistan. I couldn't find a document. I know that they've prioritized the healthcare workers, and they categorized them into 2 different, and now the elderly patients are coming in. There were a bit of confusion before that. They said children and people above 60 not to vaccinate them, but then that changed later on. So my colleagues in Pakistan at then could clarify. But obviously age related, because we know that the elderly they get the worst of this. So it's important to protect them first, and then you come down the list. And people who suffer from autoimmune problems, they are obviously quite or immunosuppressive illness, they are at high risk as well. So even if they're younger, it's important to prioritize them in your groups. No, the country like Pakistan, where the average age is around 23, 24, obviously you would not start with people above 80. It's better to start with above 60. And I think they went with 60 or 65 age group. In UK, one of the reasons the death rate was quite high is because of the nursing homes and the elderly population, the 80 and 90. Once the virus spreads to one person in the nursing home, it just affected everyone, and so many deaths happened in the care homes. So the vaccination data so far, and that's again another important thing for people to know, that, or obviously the myths and the conspiracies, we'll talk about them after a few more slides. But if you look at the countries who had the COVID-19 vaccine so far, in UK we had 30 million doses, first doses, 30 million have been given already. But this graph tells you that total number of doses given per 100 population. And Israel is at the top. 111 they had so doses per 100. So obviously lots of people had second doses as well. That's why the total number of doses are higher. Then comes UAE, United Kingdom, USA. So all these countries who are rich and can pay for vaccines, and who actually were involved in the trials and had some sort of patent on or power to buy these vaccines, they did, and they vaccinated their population, and people took it here. In UK, our uptake rate on average is around 90%. In our Pakistani community, it's running around 70-75%, but average rate is around 90%, which is quite good. But if you look at Pakistan, we have not even, this is the data, very recent data, 16th of March. We actually have not even left the baseline. And I was looking, Pakistan has vaccinated 0.001% of the people, 350,000, 0.01%. So Bangladesh and India have done slightly better when we look at the total number of doses per 100 people. So we've got quite a lot to catch up. But yes, there are more vaccines on the way to Pakistan as well. So I know the government is working to get more vaccines, and hopefully this rate would increase. But obviously the worrying thing is the hesitancy, and there's data out there that Pakistan is the highest country in the world when it comes to vaccine hesitancy. So even if you have vaccines available, if the healthcare workers or the patients don't, general public don't take it, then it's not going to be of much use. So that's why it's reassuring to tell your patients that the Jews and Christians and all the non-Muslims, you think that they are doing some sort of conspiracy against you. They are the ones who are taking these vaccines. So now I'm going to go through some of the common myths which you would hear quite often. I know all of you probably already know the answers of these myths, but it's important to give an evidence-based answers to your community member and to your patients. And thank you again to British Islamic Medical Association for preparing these slides. So like we discussed before, the things which you hear quite often is that COVID is no more dangerous than flu. So actually there are studies which are 10 times more dangerous than normal flu. And I've already shown you the data, how dangerous it is and how many deaths have happened because of it. Then saying that COVID deaths are being exaggerated in European countries. Against the evidence is totally against it. We had in UK more than 130,000 excess deaths. Yes, at the start of them, the reason why the myths started building at the start of it, when we did not have testing available. This time last year, people started coming to hospitals and some of them were dying, but we did not have testing kits, even in UK at that time, to test people. So sometimes people were labeled as COVID positive without having the proof of the test. But this is something like, is a very common medical practice where you know that the probable cause of death is this based on my clinical experience, but you don't have proof for that. But that happened obviously at the start, and later on we had plenty of testing kits available. So people who tested positive and died within 28 days of testing, they were labeled as COVID positive deaths. And actually the studies say the actual number is much higher than what we are quoting. But obviously the thing which you hear, the biggest thing is against pharma companies. And we say the pharma companies, they are no angels, they are no saints. However, one needs to have this in the prospect that we all of us take medicines. Some of us, our parents, our relatives, our patients, we give them medicines all the time made by these pharmaceutical companies. So if they have done some unethical practices in the past, that does not mean that everything else they do is bad. And secondly, people usually quote, look at the Pfizer or GSK or other companies, AstraZeneca, they've been fined millions there and they fined X million amount of dollars there. That tells us that our regulatory bodies are working. And the good thing in most of the developed world is that the regulatory bodies are very independent, and most of the physicians actually are part of these approval processes. So they're quite independent bodies. So when they levy fine on these pharmaceutical companies, that means your judicial system is working. So saying that pharma companies are evil, do not trust them, do not take the vaccination they make, it does not make sense, because you take all the other things. However, this bit is quite genuine concern. And in December, when the vaccine started coming, I had this concern as well, that they're approved too quickly. So are they using us as guinea pigs because they're approved too quickly? But but when you actually look at all the data, you realize that yes, they have cut the red tape, but they have not cut the corners in developing these vaccines. It's the unprecedented worldwide effort. पूरी दुनिया के साइंसदान, पूरी दुनिया के governments, they got together, and when people get together, they can do things. Volunteers, I know for Pfizer, 44,000 volunteers they had more than 100,000 applicants to be volunteers. For every vaccine, normally अगर आपको trial करना होता है, it takes you years and years to get the proper volunteers, and this time it was not a problem. Or the regulatory bodies, and they started following this from the phase 1 trial. Normally you take regulatory bodies, once all the trials complete, then they get it. But this time regulatory bodies, they started following it from the phase 1 trial. That's why all this process completed quite quickly. And if you look at all the data available, and all the data is quite widely available. I think for Sinopharm, it's slightly difficult to get hold of, but most other vaccines, it's quite widely available. And you can look at all the data, phase 1, phase 2, phase 3 trials. And actually, it satisfies all the medical criteria of you require for a double-blind randomized control trials. The data fits all the criteria. So scientifically possible safety, what you can offer, these vaccines are offering you that. Now, long-term side effects and those type of things, obviously no one knows. However, with our medical experiences, when we start new medication, yes, it takes years sometimes to know the side effect. But we know vaccines before, we've used the similar vaccines before, and we have fairly good idea what the long-term safety data is. But at the end of the day, what I tell my patients, I was doing a talk the other day, and someone asked me this question, that how sure you could be of the long-term side effects. Well, the thing is, we know the short-term and long-term side effect of COVID. It's really bad. In UK, actually, in every city, we've started long COVID clinic. There's so many patients. There are some studies that up to 10 to 20% of patients end up having long COVID symptoms. There's hardly a day when I do not see a patient in my clinic who's suffering from long COVID symptoms. That after 2 months, the definition, by the way, there's a nice guideline on long COVID. If you have a time, have a look. That if you got symptoms for more than 4 weeks, we categorize it as long COVID. And symptoms are a huge variety, starting from fatigue, body aches and pains, to neurological symptoms, gastroenterological, cardiovascular, pericarditis, heart failure, renal symptoms. There are plenty of long COVID symptoms. So we know fairly well the short-term and long-term side effects of COVID. So compared them with the vaccine, it's extremely safe. You had almost 3 million deaths all over the world. How many deaths we had due to vaccine? Hardly any. So there's no comparison between the short-term and the long-term side effects between the vaccine and the COVID. The other thing, which is again probably a partly genuine concern, the vaccines contain aborted fetal cells. And by the way, some of these myths you might not have heard, but what I'm telling you is something of fairly common. If you go on internet, they're quite widely available. So if you have not heard it, or your patients have not heard it, they actually would soon coming to you with it, because the word spreads quite quickly. So aborted cells, they don't have any aborted cells. The actual vial of the vaccine actually does not have any aborted fetal cell in it. However, as the vaccine development process, and it was used in AstraZeneca vaccine, some of the fetuses that got aborted had miscarriages in 60s or 70s. They took some of the cells of those kidney cells of those fetuses, and they used those cells to grow viruses in the lab. But the cells we're using now are not the cells which are aborted now. They're the same fetal cells. It's the 6th or 7th generation of those cells. They keep on growing them in the lab. So no more use, because the technology has changed. They don't need to use this. It's from the 60s and 70s, some of those aborted cells, but they are only used to grow viruses. None of these fetal cells are actually in the final product in the vaccine. So it's important to realize that. So vaccine may modify your DNA. That again, I don't have to tell you about this. That's not true. Vaccines are unsafe for pregnant ladies. That's why pregnant ladies are not being given. As a doctor, all of you know that pregnant ladies are not involved in the trials, and this is what you tell your patients. You look at the end of BNF or your pharmacopoeia, most of the drugs, it says not indicated for pregnant ladies because they were not part of the trial. However, in UK, we've started giving vaccines to pregnant ladies who are vulnerable. So the guideline for, at the moment, the guideline is the children under the age of 18 and pregnant ladies, the vaccine is not licensed to be used in those. However, the regulatory bodies here have left it on the clinician to decide when it comes to both of these groups. And I know lots of pregnant females who suffer from asthma or serious underlying medical problems. They have been given vaccines. Because they were not in the part of the trials, that's why the license was for that. But it's clinicians' job to obviously counterweigh the COVID problems, and pregnancy is one of the high risks for COVID, and we had lots of intensive care admissions for pregnant ladies. The nurse took a COVID vaccine and died. That's not true. She later on came. She had a vasovagal syncope, and she was quite normal. People talk about PCR, that's inaccurate and overestimates. No test is 100% accurate. The false positive and false negatives happen in every test, but the PCR is the best we've got available. It's fairly well validated test, and there's nothing better than this available. But again, if you say that test is inaccurate and making lots of people positive, someone today sent me a text from Pakistan that in Islamabad, lots of children are having hay fever, and through false tests, they're making them positive for COVID. Well, you may say that the tests are inaccurate, but that does not justify it would not explain why the hospitals are getting full and why the intensive care units are getting full. So PCR is accurate. And someone again the other day sent me a video that the person who made the PCR, the scientist, he said that the test, I did not make this test for COVID. Again, this is not true. He actually died even before the pandemic happened. So he never said any of these things. In Pakistan, again, another thing you hear quite often, and people have mentioned it, that they use this to chip and track you. And we hear this quite often here as well. Even before COVID, they started saying there's a 5G mask. They actually started burning these 5G masks here, that the COVID starts because of that. And because in Wuhan, they were actually at the same time, they were installing 5G when the COVID pandemic happened. But before that, 5G had already been installed all over China and other places, and pandemic didn't happen there. The fact is that they have much cheaper and better ways to monitor you. Your mobile phones, your banking cards, all the other things, they don't have to put chips in, and there are no chips. All of us have seen, and actually these vaccines, for example, if a vaccine is made in India and it comes to Pakistan, don't you think that people in Pakistan would know that if there's a chip in there? So similarly, these type of things happen all over the world. So there are no chips there. The ingredients are haram. This is not again true. It's obviously the job of the scholars to tell something is halal or haram, but we know that there's no animal products in any of these vaccines. So they are suitable for vegetarians. They are kosher, and lots of scholars have already given fatwa about it. So they're not haram in their ingredients, and they're actually not haram in their effect as well. If anything, there's some scholars who make it mandatory for Muslims to take these vaccines. Another common myth that makes you fertile. This myth actually started from a German epidemiologist who suggested this anti-synuclein antibodies may get released with these vaccines. But that scientist himself later on come back and say that there has no evidence that this anti-synuclein 1 antibody has been released and it doesn't cause infertility. However, this anti-vaxxer media, mainly the right-wing anti-vaxxer media, they took this, so it makes you infertile. In UK, we had the Royal College of Obstetrician and Gynecologists. The president of Royal College has given clear guidance that there's no evidence that vaccine makes you infertile. Actually, there have been people, young ladies who were in the trial. Some of them later got pregnant as well. And we've been using this vaccine here for more than 3 months now. And lots of my colleagues, females, men, have had vaccine, and there's no issue related to pregnancy. And yes, you will see some doctors on the media, fancy dressed white doctors from the West talking against vaccine. But the fact is that most of these doctors, someone actually sent me a website the other day, UK-based website. I went on the people who are behind that website. Out of 10 doctors who were written, only 3 of them were medical doctors. The rest of them were naturalist, herbalist, osteopath, those type of things. And out of 3, 2 of them had already been removed from GMC because of the previous lies they've done. And 1 has taken retirement, and they were all family physicians. So again, one needs to look at what type of doctors are giving you this information. But all the major healthcare bodies, all the scientific journals, not a single regulated healthcare body anywhere in the world would tell you the vaccines are not required, because it doesn't make sense. So no medical profession would tell you. Liability of pharmaceutical companies, yes, in UK, the government made this law that pharmaceutical companies would not be liable if vaccines have problem. Whether we agree with this law or not, they did that mainly because they wanted to incentivize the research. But that does not mean that the government is not liable. That does not mean the doctors are not liable. And that does not mean the pharmaceutical companies are completely off their liability. The liabilities are there. So people are dying from COVID-19 vaccines. The fact is people would die. If 10 million people had vaccines, 14,000 would die anyway for any reason. So having vaccine and then dying afterwards does not mean that you died because of vaccine. So it's a job of the scientist to, and you've seen the recent example for AstraZeneca and the blood clots, the central sinus thrombosis, and it became quite clear afterwards that the link was not with the vaccine. If 7 or 11 people out of 17 million had it, that's the normal epidemiology of this disease. So there was no link between the vaccine and the thing. So I'll just, sorry, I've taken the extra time. The basic thing to remember is to tell your patient that this is real. It's not something, a conspiracy which the government has or someone sitting somewhere has made. We have seen so many deaths around us here in UK and in Pakistan. Lots of deaths have already happened. And the information needs to be taken from the trusted resources. So if someone is on Facebook and they are fancy looking white skinned person or some professor sitting somewhere who are telling you something, go and double check who they are. But at the end of the day, come to people like you, come to the doctors or nurses or scholars who you know and ask their advice. But at the end of the day, we shouldn't force anyone. It's patient's choice, it's their choice, but it's our job to basically give them fully informed decisions. So thank you very much for listening, and I'll pass on to Dr. Jalil to take it from here.
Okay, thank you very much, Dr. Adil. It was really a very useful talk, and I hope most of the questions people have, the myths. And as you mentioned, BIMA has already done a lot of research on it, and most of the myths similar in Pakistan, and that's the good one. Yes, I heard the other day a 65 years plus person refused to go for the vaccine because when he heard that it's a risk of getting infertile. So obviously it is just unfortunately rumors people are spreading. I would like to quote one of the ayah of Quran here, where Allah Jalla Jalaluhu says, "Oh, you who believe, if a fasik, liar, evil person comes to you with any news, verify it, lest you should harm people in ignorance. Afterwards, you become regretful for what you have done." And similar way, as you all know that it's a very famous hadith of Prophet Muhammad sallallahu alaihi wasallam. Should I tell you what is a blatant lie? It is a rumor circulating among people. So we as healthcare professionals have a very big responsibility here, and we need to ensure that if people have all these myths, and we should clarify ourselves first, and then obviously any misconception people have, we should clarify that. I'm really grateful to all the panelists. Most of the questions they are trying to answer and they've already answered. But before going there, if I would quickly request our panelists to do a quick round of introduction. I know they've already introduced themselves to the panelists, but we have a very big list of attendees now, and it's almost 88 attendees at the moment. Thank you very much to all those who are attending this important talk. So starting from our UK panelist and then moving towards Dr. Shafiq from Saudi and Hina. If you can quickly introduce yourself, and I will try to gather the questions.
Thank you very much. My name is Dr. Rizwan Al-Dina. I am a family physician in Birmingham, or as we call us here as general practitioners. I'm also part of the Birmingham and Solihull commissioning group as well on the governing body. And my specific role for that has been around vaccine hesitancy and low uptake in the BAME community, where we are looking at various options of how we can increase uptake. I'm sorry I'm a bit underdressed after seeing all of you and my COVID hair, but then there we go. Thank you.
Thank you.
Okay. Assalamu alaikum. My name is Dr. Muhammad Shafiq. I'm working as a consultant family physician in King Abdullah University of Science and Technology in Saudi Arabia, which is near Jeddah.
Yes, Hina, your turn, please.
Sorry, is it me?
Yes, Hina, please.
Okay, assalamu alaikum. Sorry, I was typing the in the Q&A box. My name is Dr. Hina Javed. I'm assistant professor in family medicine at University of Health Sciences, Lahore, and I work as a sessional GP in UK as well. Thank you.
Okay, thank you very much. I would like to go to the questions, and as I said, most of our panelists have been answering the questions. So for the attendees, if they look into the question answer sessions, there are a list of answered questions. You can click on that. But I will try to clump a few questions together, just for those who joined us a bit later. So my question for Dr. Rizwan will be a more generic question. I know people have been asking, any obvious contraindication for the vaccine? I know Dr. Adil have very clearly mentioned it, but if we reiterate, so that will be helpful for our participants. Dr. Rizwan.
The obvious contraindication is allergies to either the vaccine or the content of the vaccine or constituents of the vaccine itself. Now, seeing that this is a new vaccine, it would be quite a difficult one to establish that. Relative contraindication, I suppose one of the things that we've touched on in the Q&A is pregnancy, and that is only because of lack of data, particularly around the ethical issues around testing in clinical trials for pregnant women. But I would suggest that if the lady is in a high-risk occupation, then it would be an off-license use, which would otherwise be quite important. And likewise with children as well. There is no significant data, and there are ongoing trials around vaccinations for children, younger children and teenagers. But again, for those who are with chronic illnesses or immunocompromised in any way, then those are the people who I would perhaps be considering off-license use as well.
Okay, thank you. Another question for Dr. Hina. I know somebody called it mixed match. I don't know whether that's the proper word for it. But if I clarify the question, that was if somebody has one sort of vaccine, i.e. Sinopharm or Sputnik, and then later on if the AstraZeneca or the Pfizer one arrives, so can he have the second dose from the other one?
Okay, yes, I've answered that question. Yes, that's what the mix and match is. You have one dose of one vaccine and the other dose of another vaccine. There isn't any data on it, but there are a few studies which are underway at the moment. What they have said is they don't know what the immune response would be. So it's a bit early to say, yes, you can have it, or no, you can't have it. So it's best to wait for more evidence to emerge, and then we'll be in a better position to answer that question.
Thank you, Hina. Anyone else would like to add to this, or is it?
I think the current guidelines in Saudi Arabia is that if you have one type of vaccination, you have to have the same type of vaccination because of the lack of evidence at the moment.
And thank you. And if you look at the type of technology, it differs slightly. So, for instance, the Pfizer vaccine is an mRNA vaccine, whereas the AstraZeneca is more of a recombinant inactivated virus. So I think it would be difficult we're not really comparing like for like in terms of technologies. So it's difficult, so better to stick with the same vaccine.
Another thing, Dr. Rizwan touched about the allergy. I think many people will come to you and say, oh, I'm allergic to such and such stuff, can have a vaccination. So many people confuse with allergy. And if somebody has got a penicillin and they have got diarrhea, bit of rash, then they say it's allergy. So I think the important thing is the anaphylaxis. If somebody has got the history of anaphylaxis, then you got to be careful when you give the vaccine.
Okay, thank you very much, Dr. Shafiq. I've got another question for our speaker, Dr. Adil, but you guys can add to it as well. Keeping in view the situation in Pakistan, I know Dr. Rizwan has very clearly answered that question of the participant, that how long after the COVID infection you could have a vaccine, and I know some 28 days. But keeping in view the situation in Pakistan, unless you have a very, a lot of people who have mild symptoms and who never get tested, and then they don't know, or they may get exposed again, and they're not sure whether they could be positive again or not. So is there a way of finding that? I should do some antibody test before getting vaccinated, or they need to have that clear 28 days of no symptoms at all. The reason I'm asking this because you could have been exposed in Pakistan. The situation is, they would have been exposed a lot at workplaces, especially our doctors. So what should they do? Adil, if you can please answer that.
in UK, the public health guidance was 4 weeks, and the reason behind 4 weeks was actually not because having vaccine within 4 weeks of COVID would make you feel more unwell. The reason behind that, and they have actually clarified in their guidance, the reason behind that was because they feel that the people would get confused whether it's the vaccine that caused the symptoms or it's the COVID that's causing the symptoms. So if you are asymptomatic, whether you had COVID 2 weeks ago, and you don't have to test yourself before you have the vaccine. If you're already asymptomatic, you can go ahead. We have seen patients who actually had COVID, and after 5 days, like your Prime Minister, he tested positive after having COVID. So he most likely had COVID beforehand. So there's no medical reason or justification to have the COVID test. If you're asymptomatic, you don't have, even if you have fever because of any other reason, it's better not to have vaccine, because then it will confuse what's causing what. So that's the reason this guideline was developed. So if you think you actually had COVID and they tested positive and you were symptomatic, then it's better to wait 4 weeks. But if you've never been symptomatic and you don't think that you're worried that you might have COVID, doesn't matter. You don't have to test yourself. Just go ahead and have the vaccine when your turn comes. You don't need to, even if you're positive. If you're asymptomatic, it's okay.
Thank you very much.
Sorry, in Saudi Arabia, when we recently started the vaccination here, the guideline from Ministry of Health was that if somebody had a positive PCR, don't take the vaccination for 6 months.
And I think the similar thing applies in the UAE for Sinopharm. It's 3 months after a positive COVID PCR test. And I think the issue here is that 1 in 3 of us is going to be completely asymptomatic with the new variants. So I think these are sort of arbitrary figures in terms of periods of essentially surveillance, in terms of knowing whether you had COVID beforehand or it's the vaccine which is causing that, but also giving time for your immune system to recover essentially from an assault on it, from a COVID infection. Now, I think common sense should prevail, and in that if you had something which you believe could have been COVID, then wait for the 28 days or 3 months, whatever the recommendation for your physician is. But if you've had very mild symptoms or if you've had no symptoms whatsoever, then there is no need to wait.
I think as far as I am concerned, I think why they said positive PCR COVID test after 6 months, I think they wanted to give the vaccination to those who haven't had an infection, are more vulnerable. Okay, person who had positive test and he had infection, we know they had infection, probably he has got some sort of immunity. So give the other people chance first. I think that's what the maybe logic behind it.
Thank you very much, Dr. Shafiq, for clarifying it. I think that was the most likely reason. So to make it clear to the participants, yes, if you have symptomatic COVID, and you should wait for 28 days. But if you are just worried about, because people are asking again, like, whether they should do antibody test, the answer is no. If you're asymptomatic, you go for vaccine. Other people are asking questions about their elderly parents are scared, or whether they got cancer problems. And I think Adil has very much clarified it. Even if you're on immunosuppressant, you need the vaccination. It's not, I presume, it's not a sort of live vaccine where you can get infected from the vaccine. Am I right in saying that?
That's true.
I presume they can all have it.
This is something which you hear quite often. People say, "Oh, my parent, he suffers from cancer, or they suffer from multiple illnesses." If anything, vaccine is for them. So yes, they might suffer from multiple. So they are the ones who should be protected. And by the way, there are other studies. I was doing a talk to a diabetic group the other day, and there are some again myths and some partly evidence based that people who have got weak immune system, they might respond poorly to vaccine, because vaccine provokes your antibody response. So if you're diabetic, or if you have got weak immune system, you might not respond as well, which again is not evidence-based. The studies suggest when we do the antibody levels in the trials, and for the normal vaccines which we give before as well, elderly or people who are vulnerable actually respond as good to the vaccine as anyone else would as well, and they would develop their antibodies. But if your parents or anyone is very, very unwell, it's probably more suitable for them to have vaccine. However, what happened in Norway, where they recommended caution in people above the age of 90, and it made sense because they had some deaths in elderly people after AstraZeneca vaccine, and the caution came. So the study there suggested that yes, vaccine causes mild side effects like mild fever. Some people have mild diarrhea or mild body aches and pains. So these things for most people would be mild, but if you're already 95 and you're already in palliative care and you're expected to die anyway within the next 2 to 3 months, for you, these mild symptoms can be quite bad as well. So again, we mentioned here that the common sense should prevail. So if someone's already on palliative care, they're extremely well, you expect them to die in 2 to 4 weeks, in a month or two, there's no point putting them through having even these mild side effects of the vaccine. But otherwise, they're very safe.
Well, this is where I think it gets a little bit on a gray area here, because some of the deaths in the US particularly following the vaccines, and the VAS studies is showing, is that these deaths were in people who had actually had respect forms or DNAR forms in situ, and they were given the vaccine. Now, whether they had the side effects and hence it sort of, they died earlier as a result of that, or they had complications because of the vaccine, or whether it was the actual natural illness behind that, it remains unclear. And this is where the waters get quite muddy in the sense. So I think, yes, I would probably be looking at a more common sense approach. But to be fair, there is a risk stratification in COVID. And this is what we have learned on a public health basis, that there are 4 things that we need to be looking out for, which increases your risk of serious illness or death. Number 1 is gender. So essentially, being a man puts you at a higher risk. Number 2, age. So anyone over the age of 75 is more likely to suffer from complications and death. Number 3, chronic ailments. And number 4, being from a BAME community. And I think if we look around this call, then we usually either would have 3 or 2 out of the 4 risk factors, essentially. So my message really is that we are the ideal people to have the vaccine. We should really be having the vaccine in front of everybody else, if not at the same time.
Okay, thank you very much.
Question live. It's repeatedly emerging. People are asking about the efficacy of vaccine, and probably they want a name that one vaccine is more effective than the other. The evidence so far has shown that all the vaccines have undergone huge trials and no vaccine is more effective than the other. Just remember one thing, the vaccines are there to reduce the severity of infection and to prevent the infection. And that is all you need to remember. Somebody also asked, is one type of vaccine acceptable in another country? We have got no recommendations or guidelines or policies issued by any government that they are not accepting one type of vaccine and accepting the other ones only. So there are only just, I think, probably heading towards myths.
And I would agree with Dr. because I think, sorry.
One of the famous professor in Pakistan said the best vaccine is that which is in your body.
Yes.
And it is available to you.
And I think there is the growing trend of vaccine selectivism. There was vaccine fascism, there was vaccine nationalism. Now there's vaccine selectivism creeping in. And I get quite often asked by patients saying, can I just have the Pfizer jab because it's 95% effective compared to 67% in the AstraZeneca? To be very frank with you, it all depends on where the studies were done, what time they were done, what phase of the pandemic they were done. If there was in the ascendancy phase of the pandemic, as the AstraZeneca was, the effectiveness is going to be less because that's naturally in the cycle where the studies were done. So I think the most effective, the efficacy number is actually a myth in itself. What we actually need to know is how effective is it in preventing death and serious illness. And then if you look at that figure, then it's almost 100% for anyone, including Sputnik and Sinopharm as well.
Thank you. Yeah, I think we are 3 minutes past the time, but we'll take a couple of more questions just to clarify. I know you've clarified, Rizwan, for the contraindication, but just one question people asking again. Lactating mothers, can they have? I know you answered the pregnant one.
Yeah,
lactating.
There's no reason why they can't have the vaccine.
Thank you. Another question which Dr. Adil already answered, but I think somebody went a bit specific. Renal transplant patient on all immunosuppressives, including long-term steroids for 20 years, would the vaccine provide her any immunity, age 50 plus female? Adil, please.
Yes, the evidence at the moment suggests that it would provide the immunity. because the antibodies, the vaccines triggers would still work in these type of patients as well. So obviously this patient is quite high risk patient exposed to COVID vaccine, COVID-19 and having serious COVID disease. So for these type of patients, even more important to have the vaccine as a high priority, and hopefully that would. Now at the moment, again, no one knows for how long the vaccine immunity stays in your body. That's again a separate thing, and there are some studies coming up that they might start the third booster by the end of this year. So no one knows, but at the moment, yes, they would provide you immunity. For how long, we don't know.
Thank you. And the you mentioned that long-term steroid is not a contraindication, isn't it?
No, no, it's not.
Yeah. Now people are asking about other conditions, multiple sclerosis and stuff. The answer is simple. It's yes. And there is one. Yeah, I really like that insulin vaccine nationalism. Yeah, is it from China? Is it from UK? Even initially when it came, like, you know, when somebody asked me, so we being British UK trained, we were more inclined to AstraZeneca. But that's, as you said, like now it come to vaccine selectivism, and that's the problem in unfortunately in Pakistan. But I presume Sinopharm is widely available now, so we should all get vaccinated. Before closing it, I would ask one key message from each of you. But before that, I just wanted to clarify that you know, the positivity rate. So I've got the figures now of the last 24 hours. Peshawar, unfortunately, 24% positivity rate. Swat, 22% positivity rate. Gujranwala, 19%. Rawalpindi, 13%. Faisalabad, around 13.8. Lahore, 18. Karachi, 4%. Hyderabad, 2.4, and Abbottabad 3.7. So please, you know, as I said, we are lucky now to have the vaccine, because in the first 2 waves we had no vaccine. So my request would be to everyone, you know, get yourself vaccinated. And obviously, if you like something good for you, obviously it should be for your other Muslim brothers. So before I ask the key message from you, yeah, I'm going to come to you, Hina. Yeah, I'm going to ask. But what I would like to do is,
there's a question from Nepal, actually. Somebody from Nepal.
Nepal. Okay, yeah, we'll take that. Okay, what's that question? Or you can answer it if you already got, Hina, please.
It says, any possible side effects by vaccine if accidentally taken vaccine in unnoticed COVID positive patient 80 years of age? Thank you, doctor from Nepal. I don't think there would be any side effects. I mean, if you're COVID positive and you had the vaccine is not going to exaggerate the infection. So I don't see any harm if you've taken it accidentally. That's all I wanted to say.
Okay, so before I ask about the key message from you, if I would request our attendees, I think we had 85, now it's gone down to 76. So I think people, obviously it's past 8 o'clock now. Can I request with raise of hand, after this talk, I'm sure, you know, a lot of misconceptions have been clarified for me. Thank you very much, Adil, and thank you to the panelists. So all of you now, please, if you raise your hand, if you feel confident enough now, and you can ensure that you will be able to, you know, clarify the misconception of your patients, because that's very important. As a doctor, our job is not only to treat patients, but also to do health promotion and health awareness. So please, if you keep raising your hands, that will definitely tell us, you know, how reassured you guys are. And if you are reassured, obviously, each of you see a lot of patients. And I would like to request my panelists to just do a one-liner key message for our participants, starting from Dr. Shafiq from Saudi Arabia. Please, Dr. Shafiq.
Thank you very much. It was a nice presentation by Dr. Adil Reyes. Thank you very much. I think, yes, vaccination is the hope and everybody should go for it, but don't forget to follow the SOPs. And SOPs, they do work. And if you have got any doubt, come and see the Saudi Arabia. They implemented the SOPs and the lockdown very strictly from the very beginning. And you can see the effect of those implementation in Saudi Arabia. The infection rate is very low, death rate is very low as well. So please continue to observe SOPs.
Thank you. Okay, hands have been raising, but some people may not even know how to raise hands, so they can just type yes or anything in the chat box while we get key messages from the others. Yeah, we don't want to get disappointed. Yes, it's going up 21 now. Yeah. Okay, Rizwan bhai, please.
Thank you very much. So key message from me is that Sinopharm is effective, and I know there is a little bit of reluctance against that because my own mom who lives abroad ended up having Sinopharm in the UAE, so it is very effective. The other thing that a key learning that we had from Birmingham particularly was that where there was high levels of vaccine hesitancy, we actually started doing mobile vaccination clinics, particularly because the vaccine, some of the vaccines like AstraZeneca and Sputnik will let us take it out in the community in places where there is either community center or faith-based centers, so mosques and stuff. And this is not about numbers. It is about giving the confidence. When people see their peers having the vaccinations, they actually gain confidence. And that has actually increased the number of uptake in these areas as well. So one of the things that perhaps we need to think about is to think outside the box about where we deliver the vaccines and who we interact with, particularly faith leaders, because if it comes from a trusted source, it is more likely to be accepted.
Thank you. Hina, you please. I know you can't raise your hands, you got no option, but you can raise your hands live, you know. I can raise my hand. Okay. Hina, you please.
Well, just a request to public to wear a mask, maintain social distance, carry a hand sanitizer, keep your hands clean, help us to keep the infection down. We can't afford to lose anybody, particularly the doctors, so just help us do that. That's the only message. Thank you.
Thank you. Adil.
Thank you, Jalil. I would just like to say at the end that communicate with your patients. Not every question people ask would be a myth or sign of their ignorance. It encourages questions, and when people ask questions, spend time with them and answer them. Because yes, it's okay to have doubts, especially for the new medicines. And as a doctor, it's our job to spend time with our patients and explain to them. And secondly, when you have, as a doctor, when you have vaccines, or when other leaders in your community have the vaccine, make sure you advertise it, let your other people know. But at the end of the day, tawakkul does not mean that you do not take the medicines. Diseases have come from Allah, and medicines come from Allah, and we should be grateful that this opportunity has come to us to come out of this pandemic. Pakistan is the only place left now in the world, probably 2 countries where the polio is still there. So we don't want to be the only place in the world where the COVID is rampant. When I used to work in Saudi Arabia, every time I used to land, they'll give me polio drops at my age, coming from Pakistan. So one time I went to Pakistan 6 times, and 6 times they wanted to give me polio drops. I said, please don't. So we don't want to be the place where they stay. So please, as doctors, your role is very important to educate your patients.
Thank you. Okay, thank you very much. I know a lot of other questions are coming. It's going to be a non-ending discussion, but we are running out of the time now. Thank you very much to all the panelists and the speaker. Inshallah, we will do a similar session. If you guys still have questions, you can send your questions, email it to to Waleed Zafar, and then we can certainly pass it on to Dr. Adil or our panelist. Then I would like to thank all the panelists, especially Dr. Rizwan, Dr. Shafiq, and Dr. Hina Javed, and last but not least, the speaker, Dr. Adil, who is also my class fellow. So thank you very much, Adil. And inshallah, thank you for clarifying all the myths, and inshallah, we will take you on doing other sessions, especially for our local doctors and local clinicians here. And inshallah, enjoy the rest of your Sunday. Jazakallah khair. Thank you very much.